Uh, there we go. I got it wrong. Recording in progress. All right, guys, hang tight. Always takes me a minute to share these correctly when I'm in between two computer screens. So I'm going to do this and then I'm going to do this. And are you all seeing my main slide? I see head shakes. Yes. Okay, great. Okay, thanks for joining me this afternoon. I have two cases that I'm going to present specifically. These are just lesson learned. The first case is about all these kinds of mistakes I made with one specific case, and you're going to have some homework when I'm going over that one. And the second one is really about a case. My hope is that we can all learn from in terms of what our patients go through when they're getting treatment from us. For those of you that have sat in lectures with me before, you're going to know that it's heartbreaking. I don't actually have any farm pictures in this presentation. I don't know what I was thinking. I don't know how I know I see your face, Derek. I'm so sorry. I smushed these two cases together from another presentation. I realized I didn't have those in here. So your homework as I'm going through this first case is that I want you to jot down, boy, all the mistakes that I made and all the ways that things could have gone wrong. And then we're going to come back collectively and talk about those afterwards. And Kelly, I'll ask you, I'm not always the best at seeing the chat box when I'm in presenter mode. So if anybody has any questions in between, please feel free to just unmute and share. And if anybody has any questions during, please feel free to share. This first case was a long time ago, so chances are you may ask me questions that I may not remember. For the purposes of just learning from it, I may make some answers up, but the second case is a lot more recent. So case number one is how I dropped the ball as a supervisor. So you're going to understand in a minute why I'm presenting on both parters at the same time, but this description of individuals, we've got Nancy and Keith. Both Nancy and Keith are in their early 30s. Quick bio, they were referrals to our COAT program from another program that shut down unexpectedly. They are a married couple with 3 children. They both meet criteria for opioid use disorder, severe on maintenance therapy. They had been in long-term recovery when we met them. Also both met criteria for tobacco use disorder, and Nancy also met criteria for generalized anxiety disorder. Just some additional background information. Nancy and Keith met during high school. They were high school sweethearts. They became involved in active addiction around the same time, then entered outpatient treatment at the same time, and have both stayed invested in their recovery since entering treatment. Some lapses and recurrence of use from here and there, but both really invested in their long-term recovery for a while by the time we met them. Previous treatment experiences included a quote unquote cash and carry clinic out of Pennsylvania. And then they had been in a traditional MAT clinic in West Virginia prior to our COAT clinic. As mentioned previously, their last clinic closed down unexpectedly. And what I mean is they showed up for their appointment that day and there was a notice on the door that says, "We are no longer open." So they were desperate and scared when they reached out to us. So here's the order of events. Nancy was first seen of the couple. She was the first one seen for a new patient intake on a Wednesday. The intake was supervised me, but facilitated by a counseling intern who worked in the clinic 1 day a week. And so that intern completed the interview with Nancy. During the intake process, all of the medical background information that was collected in the medical screens prior to the interview, she completed a pregnancy test, and that initial pregnancy test was positive. And she was very, very surprised about that news during the intake. So we completed the intake with her. We got enrolled in our COAT program. A few days later, the confirmation results from that pregnancy test were negative. And so I called Nancy with this update, who was very happy to hear about this news. And I did not share this update with the intern. The intern was there 1 day a week. The day I called Nancy happened to be the day that the intern was not there. And I did not tell the intern this. So for your homework, you should be writing some stuff down. Order of events, part 2. Keith was seen, the husband was seen for a new patient intake the following Wednesday. That intake was facilitated by the same counseling intern that saw Nancy. When she learned that Nancy and Keith were married, what do you want to guess what happened? Anybody want to verbally unmute or drop a idea in the chat box? What do you think that intern said to Keith when she met Keith and recognized that he was married to Nancy?
Congratulations.
Yes, 100%. Boy, did she congratulated him on that pregnancy. Well done, Gold Star, for your great guess. So during the walk from the waiting room, so here's how it works when I supervise interns in the past is I'm in my office on a computer screen viewing the room where this intake is going to take place. The intern is going out to the waiting room to grab the patient, walking them back to the room that the interview is going to take place in. Again, I'm virtually. And so during that walk from the waiting room to that office, when she learned that Keith was married to Nancy, she said, "Congratulations on the baby." I was unaware of this, that this conversation had taken place, but at the start of the intake that I virtually observed, and then throughout, what I noticed was that Keith seemed off. Didn't seem upset or anything like that. Didn't seem sad, but boy, he just seemed off and confused. When the intern completed the intake with Keith, the plan was for her to, come back to my office to evaluate, discuss the case, kind of figure out next steps. And so during that process, I observed him in this room call his wife and ask what in the world this intern was talking about the pregnancy news. So let's talk about our goals and navigating an ethical error. So here's what happened is that we broke confidentiality. So we need to identify the error made. That was the error that was made. What we then did, let me go talk about the goals. I'll talk specifically what we do. What we always want to do is identify the error made. We want to contact all parties involved. We want to review the ethical tiers involvement. In previous ethical discussions I've talked about, we've got our federal mandates that we want to be mindful of, our state mandates, our own personal licensing. All of us have different licensing certifications in here, board of ethics that we abide by. We've got our agencies, code of ethics, and then our own personal one. And then we want to be transparent in our communication as much as we can, as much as that fits in within the confines of confidentiality. So we recognize that we broke confidentiality. I immediately reviewed the situation with my supervisor. Our plan at the time that we figured out was the intern talked with Keith about what had happened while I was talking with Nancy, and then the four of us were able to talk at the same time. I don't remember. I'm sure it was just I'm sure I just put Nancy on speakerphone and brought Keith into my office. Other steps are that I informed the intern's academic program about the incident, and then I debriefed the situation further with my supervisor after, and then with my supervisee. So I could make sure I was showing up to be a helpful person for my intern, to also help both of us kind of learn through what happened. The couple could not have been nicer about it, which I actually think is likely due to a product of stigma, and I'm going to talk about why in a little bit and get your all's thoughts on that. So here's my 3 questions. First one is, what are some potentially dangerous outcomes that could have taken place from this? Second one is, what could have been done to prevent this from happening? And then third, how could stigma have played a role in this situation? So we'll start with that number 1. I'll open the chat box, but then also please feel free to unmute yourself. What are some potentially dangerous outcomes that could have taken place from this?
Divorce.
Divorce. Peter's right off the bat. Yeah, absolutely. Right. Could have led to a huge conflict between the two of them about what was the truth and perceived truth. So, yep, that could have been a huge deal. Just right off the bat, it's a big one. Nice job, PJ. What else?
Anger, accusation from the husband.
Yep, 100%. Absolutely.
Violence.
Say that again?
Violence.
Yes, absolutely. So let's talk about, let's pretend that she had been pregnant. Here's what could have happened is that maybe she wasn't planning on sharing her pregnancy with Keith because Keith is violent. And we set her up with that. Oh, Dr. Arvon just wrote, oh, I'm missing things in the chat box. Goodness, I'm so sorry. Yep, so Derek wrote very right off the bat, anger, accusations from the husband, stress leading to relapse. Absolutely. How did this situation potentially lead to a relapse for somebody who's been in long-term recovery? Dr. Arvon shared, we had an incident where a husband shot his wife and killed her at a local urgent care. Oh, I'm so sorry. That's awful. Yeah, so maybe Nancy wasn't planning on keeping the baby and we took away her right to privacy. Maybe Keith was abusive, and so we put Nancy and the baby in jeopardy. And maybe it wasn't, again, maybe Nancy was pregnant and it wasn't Keith's baby. And again, we put everybody's health in that situation in jeopardy. Anything else missing with number one before we go to number two? Okay. So number two, what could have been done to prevent this from happening? That was part of your homework listening to this case is where are the different steps? What could we have done? What could I have done differently? Because I could have done a lot differently.
Shouldn't all parties have been emailed at the same time?
About the
About um, the information that was provided that she was no longer pregnant.
Oh, good point. Yes, yeah, right off the bat. Thank you, Ricardo. So well done. What I should have done when we notified Nancy about it, I should have notified the intern as soon as possible. I should have either contacted her while she, found a way to message her prior to coming back to work that next week, or the minute that she got there on next Wednesday for her shift, because that was her patient that she saw last week. I should have let her know 100%. Hey, that patient that you saw last week, here's an update on her. So great suggestion. I think there's great things in the chat box. I need to scroll up.
Yeah, so the chat one says a pre-huddle regarding new intakes.
Yep, 100%. Oh, sorry, go ahead.
No, you're fine. Go ahead.
Yeah, one of the biggest errors was not having a pre-huddle regarding new intakes, right? Sometimes what our excuse is, I'm sure what my excuse that day was, I'm really busy, I didn't start work until 9 o'clock and that's when the intake was scheduled. Nope, that's not an excuse. That's on me to rearrange some things to make sure that I have time to prep her. Tony made such a good point is prepping the intern student to remember that although they're married, they each have their own privacy. That sometimes gets lost. I would say it happens more. I'm going to be very careful to not throw us Appalachian providers under the belt, but I feel like that happens. Folks are so related. There's so many different ways people are related in program, and we're a small town, so everybody's somebody's neighbor, and we can accidentally make the assumption that because they're related, they're talking about their medical care with each other, or that they're related, that they're on good terms and talking about these in general. So always want to remind people that just because they're related, they still have their own privacy rights. David, very well said, Dr. Baltier, never talk about pregnancy unless consent from patient, right? A consent from patient, excuse me. So in sharing that information with Nancy, I could have also had a further conversation with her about, hey, is there any additional way that we can support you or your family with this news that I'm sharing with you that you are not pregnant? Let me scroll down in my... what kind of ethics trainings did the intern have? Yes, another great question, right? So while they, again, it's one of those that's so old, I don't remember what kind of training they have prior to starting their internship with us. I'm sure it's not enough, right? I learned new things about ethics every single year, and I even, in fact, teach ethics. So regardless of what other training she had, it needed to be reviewed regularly. Here's also best practice. Best practice would have been to not have the intern do that second intake to begin with, right? Some of us don't have that option, right? Based on how small our agencies are and how many staff that we have, you don't always get to have that choice when there's a dual relationship or conflict of interest. You don't always get to have that option of not seeing that person because you just saw their spouse the week before. But we work in a large enough agency, we could have made that happen, and I didn't. So to me, that was my biggest first mistake. Just reading my notes, should have had the time to let the intern know the update on Nancy's pregnancy status. Absolutely should have reviewed the need to be extra mindful of confidentiality when there's that conflict of interest. Great errors you have identified. Any other errors? Anything else we could have done differently? Great discussion from you all. Thank you. Intern should not congratulate. Did you make, oh yes, that, yeah, absolutely. That should not have been the place. Also, even if Nancy and Keith knew about that, right? Sometimes we got to talk with people about maybe it's not an exciting thing that she's pregnant. So kind of what we did is project our own opinions about pregnancy onto that couple. So great point, Dr. Baltier. I thought that was a misspelling, Dr. Baltier. I thought you were saying intern should not graduate. And then the last question, how could stigma have played a role in the situation? It's not meant to be a tricky one, but it's a little hidden underneath. And it has, to me, it's related to how incredibly nice they were actually about the situation. Any guesses? Well, here's my guess, or here's my opinion. It's not fact, but you guys tell me if you agree or disagree. I fear that, again, they were so nice about what happened. They were incredibly kind to the intern and to us about what happened. I fear that they didn't communicate their true anger about it because they sort of felt stuck with us as a treatment center, right? They had just gotten removed. Yes, thank you, Sarah. You nailed it. They may not want to have caused an issue due to worry about being accepted into the program, right? They just lost their other program, their other home base, literally overnight. They were desperate for care. And my fear is they felt like they couldn't speak up because of their SED status. Did they think, well, their opinion wasn't valid? And so that was a concern I have. And so it sounds like, Sarah, you felt that same way too. Anybody, any additional agreements or disagreements with that? Okay.
That was my thought, was that they might have felt afraid to say anything out of fear of reprisal, whether that be, not getting into the program or something else.
Yep. Very well said. Lauren Miller said, coming from a family physician background, I think the biggest issue is thinking it's okay to discuss one spouse or family member's health issue with another. When this rule is followed, then the rest doesn't happen. Yes, you're right. That would have been another way to fix that. Well, you guys did great with your homework on that one. Well done. I think I always say this, I'm so grateful to be a part of this teaching hospital and with my teaching colleagues because, not again, this was from a very long time ago, but I remember clearly not one person shamed me from these mistakes, but really helped me see, I just missed something in the chat box, as an opportunity to see this as a chance for growth. In fact, I really feel that same way about this SUD Echo group. I think this is such a kind and judgment-free group where we really get to learn from each other, both our successes and our mistakes. And I'll tell you, I do things much differently with my interns now, and I learned from that scenario. Yeah, Dr. Gorby so well said, shame. Stigma, that shame of stigma is just so powerful. Okay, so where's my arrows? That was case number 1. Here's case number 2. Your homework with this one is that I want you to keep a running tally of all the potential areas for the patient to receive stigma or discrimination or judgment of some kind. And so we'll review that list at the end. And as you see, it's a long list that this incredible human has had to overcome. So description of individual, we have Erin P. Erin is a 32-year-old white female. She's a single mother. I need to move my squares over here. Single mother living alone and raising 2 biracial children, ages 8 and 6. She works part-time at a local coffee shop and is enrolled in online college. Her diagnoses are opioid use disorder, severe and sustained remission, cannabis use disorder, moderate and sustained remission, tobacco use disorder, and PTSD. Just a little bit more detailed background on her. So she was raised by her biological mother until 16. Mother was diagnosed with schizophrenia, was in and out of treatment. Erin did not have a relationship with her biological father at all. Mother completed suicide when patient was 16. At that point, she moved to Oregon to live with her maternal aunt and uncle. She lived with them from 16 to 18. She moved out at 18, transferred to West Virginia around age 20. She had 2 unplanned pregnancies at age 24 and 26. She met her former partner while in active addiction. They entered treatment at the same time, and she remained consistent with treatment. He did not. He was the biological father of her 2 children. There's a history of verbal, emotional, and physical abuse from that former partner. Physical abuse occurred when partner was intoxicated. Local police were called a few separate times, both by her a couple of times and by neighbors a couple of times. She separated from the partner in summer 2021 and moved into her own home with the children. Just brief history on her. At age 13, she first began using substances during junior high school. She started with alcohol, cannabis, and nicotine. Began using hallucinogens and cocaine at age 16. Also at age 16 is when she began using opioids, and at age 24 enrolled in MAT. Patient is currently enrolled in our coach program and has been for the past 8 years, starting at age 24. Has approximately, my years may be off because I think I presented this a year or 2 ago. So ignore that. Has approximately 4 years of continuous sobriety, maybe 5 by now. Patient's in our advanced monthly phase of the program. She also attends individual therapy voluntarily on a biweekly basis. She attended peer support meetings consistently during her first 2 to 3 years in recovery. Attendance has dropped off in recent years, and she has responded very well to motivational interviewing and CBT. I mentioned earlier her diagnoses. Specifically, I want to talk about her symptoms of PTSD. She experienced this, freeze up or shuts down in conflict. She avoids thoughts and feelings about her past trauma. Feels a sense of detachment from others, has made an enormous amount of progress with that. And a lot of her mental health journey is about dealing with this guilt and shame about how her children have been impacted by what's happened in her life and her struggle with low self-worth. And so our primary goals in treatment have been to person-centered. These are her goals that we work towards, was develop sobriety, maintain long-term recovery, separate from abusive relationship, and work on trauma healing, emotion regulation strategies, develop self-esteem and confidence, work on boundary setting, and positive parenting. And then the barriers have been, the symptoms of her opioid use disorder, the symptoms of her PTSD, the various relationships in her life, most specifically that abusive relationship, attempting to juggle parental responsibilities on top of clinic responsibilities, all while having financial struggles, a lack of transportation, and just dealing with general stigma. So here's the 4 questions I'll pose to you all. I'll read them all and then we'll go through them one by one. Number 1, where could stigma have played a role in her childhood? Number 2, where could stigma have played a role in her treatment? Number 3, where could stigma have played a role in her utilizing of community resources? And then lastly, what are some strategies or interventions that you might have used with her to help her overcome the stigma she may have experienced? So first question, where could stigma have played a role in her childhood? I'll keep my eye on the chat box, but also please feel free to just unmute yourself and share. Yes, thank you, Jackie. Parental mental health problems, right? So trying to navigate her mom's own mental health journey, what that meant for her mom being in and out of treatment, what happened to her while mom was in and out of treatment. They did experience homelessness at times. So that was a huge, significant area for stigma. Substance use in her youth. Yep, right on. She started that when she was in high school age, and that was partly when she was living with mom and with her aunt and uncle. I don't remember her aunt and uncle's opinion or understanding about substance use, so definitely a potential area for stigma there. I do remember that she felt very out of place living with them. Derek, yep, well said. Parents being separated, not having any relationship with her biological father, having unplanned pregnancies, absolutely. Parental suicide, that comes with its own host of incredible judgments from others. So well said. And potentially her own judgments that she had to work through. Anything else with number 1 before we move to number 2? Those were all great. Number 2, where could stigma have played a role in her treatment? Derek already actually mentioned one of them. So her unplanned pregnancy. So she was pregnant while she was in treatment. And while there are a number of incredibly awesome treatment providers like you all on this call that are really supportive of people that are in recovery and pregnant, there's a lot of providers out there that aren't. So that was an area of stigma for her. She did talk about pregnancy number 2 felt better and more positive in terms of what that treatment looked like for her than pregnancy number 1. Intimate partner violence, absolutely, Jackie, so well said. So that's an area that we attach judgment to other people for. You know, in the addiction field, a common statement we will hear from people in the community is, why can't you just stop using? And another stigmatizing view that we will attach to people that are a part of domestic violence is, why can't you just leave them? And so she for sure experienced that. Another, I should just read my notes that I wrote. She struggled to make it to her appointments at times due to her schedule, which to us could look like non-compliance. But for her, she was doing the best that she could to juggle everything that she had going on. And then, of course, we know, as I mentioned earlier, mothers are particularly stigmatized when they are utilizing MOUD treatment. Hold on, I scrolled up. PJ said stigma surrounding MAT, especially in self-help meetings. So great point. So this case is a little bit is a little older, and the PJ, I'll ask you, the attitude about utilizing MOUD in our local AA and NA meetings. Do you feel like it was different, 10-ish years ago than it is now?
I feel like it was very different 10-ish years ago.
Yeah.
In the 5 years that I've been here in Morgantown, it has changed drastically.
Yeah.
From when I first entered recovery here in the Morgantown area, that attitude has changed a lot.
Yeah. Yeah.
But in other areas that I have been to, away from Morgantown, that attitude still persists.
Yep.
Still to this day.
Yes. Yes. PJ, thanks so much for that. Yeah, so accurate. Yeah, it's good for if you've not had an opportunity to attend peer recovery meetings in your area, if there are any that are open, it's not a bad idea to check them out to kind of see what the attitude is about treatment, or to ask your patients that are going to meetings what they experience as the attitude about receiving MOUD as part of your treatment. Lauren wrote, sorry, my scroller is not working very well. Lauren wrote, positive side of stigma as part of treatment would help her see how she was able to rise through so much adversity and stay in recovery to help her develop pride and self-esteem. So well said, Lauren. I wish she was here to read that 100%. Yeah, this human's like one of the strongest humans I know. So I love that you recognize that, and I would love for her to be able to read that. Dr. Gorby wrote, biracial relationship partner who dropped out of treatment. Absolutely. So let's talk about West Virginia and the culture of West Virginia around our BIPOC community members. She definitely experienced that a lot, watching firsthand the discrimination that her children received. And then also herself receiving that. And then it felt really complicated. It got sort of even more complicated when they weren't in a relationship together. So Dr. Corby, so well said there. Number 3, what Where could stigma have played a role in her utilizing of community resources? Some of you have kind of mentioned a few of these. Any thoughts there?
Derek had posted in the
There.
chat that just having an SUD can impact access.
Yep, so well said, Derek. Thank you. So having that SUD as her status, being on MOUD, prevented her from being able to receive certain community resources. So well said. Accessing treatment, again, that became so messy of trying to access treatment, trying to get her kids into care, get them to school, take care of her parental responsibilities. All of that together was so difficult. Sarah mentioned getting housing. Absolutely, that was very difficult. We do not have an abundance of housing here in the Morgantown area. Lauren wrote fear to utilize resources in fear of judgment from any one of the stigmas we have said. Yes, absolutely. So an example is, it was mentioned that she and or the neighbors called the cops a few times, and she talked about feeling like the cops didn't take her seriously at times. And there were times she was worried about her and her kid's safety, and the cops would come and then leave. And her hope was that her partner would be taken to jail to kind of give her and the kids a reprieve and an opportunity to be able to get out of there. And she didn't get that. Number 4. So what are some strategies or interventions you might have used with her to help her overcome the stigma she may have experienced? Actually, Lauren gave a beautiful example earlier of just helping her reframe how this adversity that she's been through, help her see just how incredibly strong she is from it. I wish she didn't have to be that strong, but yes, how strong she is.
I really think that would be in my mind, that would be like one of the most helpful things is helping her to reframe that, because I teach a section in a class that I teach specifically surrounding stigma and MAT, and the national statistics say that the people being prescribed medication are the number one stigmatizers of people being prescribed medication, which would be themselves.
Yeah.
And that would also could play a role in her not wanting to utilize the community resources.
Yeah.
We often feel like, oh, and this goes for substance use disorder as well. We often feel like, oh, we don't deserve this help.
Yeah.
We won't, and we end up stigmatizing ourselves as a
Yeah.
result.
Yeah. Oh, so well said, PJ. Yeah, so meeting somebody like her with just unconditional positive regard, validation, giving her as many resources as possible, and then also having to repeat that. I don't know if you all have ever felt this. I know I have thought this before when a patient's asking for a resource. Sometimes I've thought to myself, oh, I know I've given you this like 5 times before, or I've given this to you before and you've not used it. I've had that thought. It's a terrible thought. That's why I go to my team, and my team smacks me in the back of my head and says, what are you doing? Maybe this will be the time they use that resource. And she's a perfect example of that. There were times that she didn't use those resources until she was in a position where she could. So give her those regularly, connect her to a peer. She is somebody that absolutely benefited with working with a peer. Helping her find a supportive female peer group also was vital for her. And Dr. Gorby very well mentioned, yes, helping her understand, using proper language. One way to help her start, stopping shaming herself is really allowing her the opportunity to talk about herself in a different way. So well said. Just treating her like a human. Thank you, Dr. Arvon. Yes, yes, yes. Beautiful. Any additional thoughts on this case? Going once, twice. Okay. Well, gang, those are my cases. 1, all kinds of mistakes. which is good for, I feel like the more that we can be comfortable talking about that, and we kind of help each other identify when that's happening, not from a place of shame. And then the second one's just a good reminder for all of us of where can we remember all of the obstacles of discrimination our patients are facing by the time they show up in our office. Probably would have been longer if I had farm pictures, but that's my lesson for next time.
Give me 1 second. I promise I'm looking for that.
Oh, you're fine.